This is really exciting. I don't think you're going to ever find a panel with the quality and breadth and intellect and good looks that you're going to find in this panel that Nishan's put together here today in Niagara. So I'm very excited to introduce this group. Before I do that, just a couple things before I forget. I'm going to have to make a quick exit. I was just explaining to Danielle. I have a young daughter who has a hockey game that they planned in the middle of the Masters, but we won't talk about that. But what is important is for us to do this again at the quality that we've done. We need the support of our vendors. So we ask that you, after, please do stick around. I know people have been visiting them, but please do go out and make sure to thank them and support our vendors because they make days like this possible. But to the headline here, and I want to introduce 5 people that I've pissed off to varying degrees in my career, but we all get along now. I'm going to start from left to right. These esteemed guests contribute in so many ways to this profession that we love so much and provide a lot of value in the world of advocacy, education, business. And so at first, on our left, Justin Bates, the CEO of the Ontario Pharmacists Association, an organization that you should all belong to. And if you don't, please visit the website and sign up for your membership right now. Donnie Edwards, who is on our executive here at PANP, has been a mentor of mine my whole career and is one of the most popular faculty-type people at the University of Waterloo, only second to the person that is on his right, Nardine. And Nardine and I were just reminiscing about a time that we spent back in 2016 with the newly elected U.S. president at the time, and we're not going to talk about him or that, but it was great to see her, and it's great to see that Nardine is talking to me again after that episode. Sivapalan, who is an energetic contributor to the pharmacy profession in the Hamilton area, here in Niagara and Beamsville, has served with the college and has fought fights on behalf of the profession and stuck his neck out there, that we all owe him a debt of gratitude, and has a great deal of insights. And last but not least, another good friend, Daniele Paes, who is the woman, the face of all pharmacists in this country, a role she's taken on with great enthusiasm, despite having a husband who has all kinds of other interests that she has to, look after, but she does a great job. She balances it all, and we're all so very lucky to have Danielle representing all of us across Canada. So I'll leave it to Danielle.
Beautiful. Thank you. I'm a shorty, so hopefully you guys can all see me. My husband is also a pharmacist, so that's where that little inside joke came from. But pleasure to be here today. Thank you all for inviting me. First of all, you guys are a pretty incredible group, and I just got to say the passion, the leadership that I have already witnessed, I've been here for 2 hours, is undeniable. So kudos to this particular community. I have a personal connection to this part of the world. I got married here, and every time I come back here, it's just like a big, warm, fuzzy feeling. So maybe one day I will retire here, who knows? But the pharmacy community in this region in particular is clearly top-notch, and I'm excited to be here to have this conversation with you. So you're going to get today a little bit of a behind-the-scenes look at a campaign that we've been working on for the past several months. We are committed as a national organization to supporting the advancement of the profession, and we want to represent you well. And so this is an opportunity to get your thoughts and get your insights into the work that we're doing on a national level. As you can imagine, it's a pretty tall order to try to represent the interests of a profession when pharmacy looks different depending on where you are in the country. but we want to make sure that you see yourselves reflected in the work that we're doing. So, you know, for as long as I can remember, CPHA has been working towards a national harmonized scope of practice. It is something that we believe so strongly in because right now, depending on where you live, dictates what care you're able to access from your pharmacy team. So not only is that a problem from a patient lens, but as a practicing pharmacist, that really governs how you show up in your practice and what you're able to do. And so we've tried to highlight this inequity. Many of you would have been familiar with our practice charts. It's something that we've used to track scope from region to region. We've almost used it as a bit of a tool to monitor who can do what, where. And over the years, it's become very, very clear that, especially in the last few years, that this chart doesn't actually tell us the full story. So when we use the term expanded scope, it gives the impression that pharmacists are tapping into knowledge beyond what we're capable of. And the reality is that expanding pharmacist scope is not about expanding our knowledge, it's about expanding our ability to use the knowledge we have. So that's very nuanced, but I'm going to say it again. The expanded scope is not about expanding our knowledge, it's about expanding our ability to use the knowledge we have. And so it's about freeing pharmacists to actually be able to leverage their education. And so we have intentionally shifted the conversation and shifted our focus to raising awareness about pharmacist education and aptitude. And through our research, it's become very, very clear that there's a lack of understanding about the knowledge pharmacists possess. What do we need to do to inspire confidence in our competence? And I think that, that's not just for patients, it's not just within our own pharmacist community, but with our interprofessional colleagues as well as decision makers. So the solution, or our intention, is to help governments understand that pharmacists are being restricted. So they have knowledge and they are being restricted, or we have knowledge and we are being restricted from using that knowledge, and that is a tragedy. You don't ever want to have a situation where you have a patient in front of you, you know what you need to do to help them, and you're not able to do it because you're not authorized to do it. It just seems completely unfair. Sorry, I'm turning my back over to you. The comfort monitor's here. So our solution to the problem is increasing pharmacists' autonomy. So we're going to talk a little bit, we have this amazing panel discussion coming up where we're going to talk about pharmacists' autonomy and our ability to practice freely. So closing that gap between our education and our ability to use our education is the goal here. So we spent a significant amount of time over the last few months putting together a summary of pharmacist education. So we've done extensive collaborations and consultations with the pharmacy community. We've talked to regulators, we've talked to educators, pharmacists, students, and what we've done, and we're working with the faculties of pharmacy to try to really hone in on when we point the governments to that gold standard, that state of that offering, our full suite of offerings. What do we say? What are we actually talking about when we talk about using a pharmacist's education? And so we want to be able to create something to point to. So we've developed a benchmark. We're going to publish that in the coming weeks, so keep your eye out for that. But what it is essentially, we've taken the curriculum. The entry to practice standard for pharmacists today is the PharmD. And so we've based it on the PharmD curriculum, and I know that not everybody has a PharmD, but we'll get to that. And we've distilled it down into these 5 buckets, and we go into much more specifics about what is included in these practice areas. And I recognize that not everybody in this room has a PharmD, and I recognize that there may be a disconnect between what we present and your individual identity to who you are as a pharmacist. And what I will say to that is, to earn a pharmacy license in Canada is no small feat, and it actually doesn't really matter what degree you have. What matters is the skills and transferable qualities that you possess in being able to take on challenges. So most of you would not have received injection training for immunizations in your schooling. A need emerged. You have the capacity, you have the knowledge and capabilities of evolving and growing. That's sort of what you sign up for when you get into healthcare. And you stepped up and you delivered. And now nobody would even question your ability to offer vaccinations. And so that's the same type of logic that we've applied here. All of the things that we are presenting as the benchmark for pharmacy practice in Canada is all within our capabilities of doing. And it really comes down to your interest and willingness to do it, and then the capacity to do it, which is a whole other piece. So as we have this conversation, we really do need to put it into context. So it's one thing to say, oh, this is what we know, let us do it. But the environment is very complicated. There are many challenges within our healthcare system. We've listed a few here. Physician colleagues are not on board, and that's a problem because they call the shots in many provinces, including Ontario. And so we know that they have a very loud voice, and they have been historically influencing the practice of pharmacy for years. We know that the majority of the public doesn't fully understand our education. We know that there's beyond flu shots and common ailment prescribing, there's so much more that pharmacy has to offer and pharmacists can offer, but we just don't have that visibility. So what we're trying to do, and obviously I work in an advocacy space, so we're always trying to change the regulations. We're trying to work within our means to change the policies that have been designed decades ago. You know, pharmacists aren't even recognized as practitioners in the controlled substances regulations. That's a problem, especially if you're looking at us to help manage medications that fall in this area. This is an example, I'm not going to spend too much time, but here's an example of what Ontario Medical Association put out to help people understand what education pharmacists have compared to nurse practitioners, compared to physicians. And on the topic of mis and disinformation, it's very misleading, and it's actually not really helpful because you don't want patients to question the competency of healthcare providers that are accessible to them and have supported them throughout their health journey. So there's an opportunity for us to help change the narrative and educate our physician colleagues, and not just physician, but all of our interprofessional colleagues on what we can do. So whenever we have a hypothesis, we always try to validate it. And so we did some polling to show that, or to ask people, would you consult a pharmacist for chronic disease management? And 50% said yes. That's awesome. We then asked the exact same question with a prompt, knowing that pharmacists have extensive training on managing chronic diseases, would you consult them for advice? And it jumped 15 points. So that little prompt, just to show like this is actually within our wheelhouse, shifted their behavior and their willingness to reach out to their pharmacist. So what we've done, and this is the exciting part, is we've partnered with Spark. And Spark is helping us currently develop a public awareness campaign and a government relations campaign. And so PR and GR are an important part of successful advocacy. We'll get into it. But we know what pharmacists are educated to do. We know how that can be applied and translated into pharmacy services. And now we just have to shout it from the rooftop. We need to let everybody know. And so we're at an exciting point, I would say. Sometimes it's about timing. We're at an exciting point where the opportunities and the challenges are coming together in a really, really exciting way, and the environment is ready. And it's time for us to encourage governments to take action and to enable pharmacists to actually be able to support patient care in the way that's needed. And we need to own the messaging for that. And so if this campaign is successful, we're hoping that it will support our advocacy, not only on scope, because that's one thing, but on the reimbursement part and the remuneration, because you can be allowed to do something, but then you need to be able to do it sustainably and fairly and in a way that actually allows pharmacists and pharmacy teams and pharmacies to thrive so that they can continue to serve their communities. So again, our campaign goals are twofold. I've lost track of time, but I'm chatting too much. Our goals are twofold. We want to affect government change, and we want to increase public awareness. And the intention with the public awareness campaign is that it's one thing if pharmacists say we're really educated and competent and you should allow us to do this. It's a completely different lens when a patient says, hey, why is my pharmacist not allowed to provide this care when they know how to do it? So we're using the public awareness to put a little bit of pressure on our governments to bring about the change that we want, because people listen to constituents. So our slogan, you would have already started to see this during Pharmacy Appreciation Month, is Pharmacists CAN, because we can. And there's other reasons why we cannot, so we can get into that. But trained and trusted to help. We're gonna do a little bit of a compare and contrast to highlight the inequity that exists. So look at what's happening in Saskatchewan versus Alberta. If you were in this province, these are just mock-ups, by the way, nothing on here is actually legit, so they're all, don't call me out on that. But essentially, if you were in this province, you would have to wait in a physician's office or clinic. If you were in province X, you would actually be able to have a pharmacist support you and resolve that issue in real time through a visit through the pharmacy. So that, I think, is really meant to help people realize the inequity that exists. In border towns where you have, like, on one side of the street, you can get access to these services and on the other you can't, like, it becomes very, very clear that there's a problem. We're gonna have a website, so when you have all these social media ads, you need to send them somewhere. And so on our website, we're gonna have the ability for people who come here to take action. So write a letter, sign a petition, write a letter to your official, your representative, and other ways to actually activate the public towards this goal. So last, before I turn it over to our panelists, I want to share with you what we're calling as the hero video. Again, this is a mock-up. We are intending to film it with real Canadian pharmacists in real Canadian pharmacies, and to really change the impression of who your pharmacist is and what are the types of interactions you can expect. So this stock footage has a lot of, like, pharmacists behind a wall or in front of a wall of pills. We're trying to change that so that there's more consultations. It's very intentional in our reimagining and changing the narrative of who your pharmacist is. So I'm gonna play this.
Pharmacists can provide advice because they are educated in medicine and your health. Pharmacists can help quickly because they are often just a few minutes away. Pharmacists can help virtually, by phone, screen, and after hours when your doctor's office is closed. Pharmacists can keep you safer with clinics, vaccinations, and prescription refills. Pharmacists can even ease demands on hospitals, delivering care in communities big and small. But in many parts of Canada, your pharmacist is being held back, even though they are trained to do so much more. It's time to allow pharmacists to help, because pharmacists can.
So hopefully that made you feel warm and fuzzy. Every time I see it, I feel proud, and I think we all should feel proud about the profession that we've chosen and where we're going. And I know that the time where we are right now, depending on who you talk to, you might have a different impression on whether or not you would recommend pharmacy as a career. However, I'm really curious to talk to our panelists here, and I'm gonna start off with Nardine. I'm gonna ask you a question specifically about the education. So the education of pharmacists continues to expand, but not at the same pace. What needs to happen now to close the gap between what pharmacists are trained to do and what they're permitted to do, and arguably what they're prepared to do?
All right, well, thank you. Can you hear me? Is it working? There we go. All right, good. Lovely to be with all of you. Thank you, Danielle. That was an excellent presentation. I think I'm going to take it a couple of steps back and start by saying the pharmacy education world has been evolving for 20 or 30 years now. And so in the education space, we've really been equipping our students to practice at a level that was much higher than what they felt they were able to do in practice and what they were actually able to do. So we were graduating individuals who were autonomous, who were able to assess prescribe. They knew what to change in therapy. They're truly medication experts. And then they'd go out into our fragmented healthcare world and say, you know what, my expertise isn't being utilized at all. In fact, you know, I am unable to do X, Y, and Z. And so that was becoming really frustrating. And I think for the first time in a long, long time, if ever, here in Canada, especially in Ontario, our graduates and their education is really kind of almost at par with what is happening with their scope of practice. And as an educator, that's one of the best things and most exciting things about this time right now, is just seeing that their knowledge, their skills that they have are able to be applied and utilized appropriately in practice that lead to meaningful results when it comes to patients and their outcomes and all of that. So that's the first thing. That's the backstory. So we've been really over-preparing, and it hasn't been wonderful until scope is expanded, and now really students can apply their knowledge and expertise appropriately. What needs to happen is what we're also seeing happen right now, which the Ontario College of Pharmacists, I'm not sure if many of you are aware of this, but they have come to the schools of pharmacy and consulted with us as academics to say, hey, this is where we're expanding scope. Where is this covered in the curriculum? Is this covered? To what depth? To what breadth? And we're having that dialogue, so it helps inform what scope should look like, so that really there's alignment between regulatory and academia, which is so important. If you are not doing that, then you really are out of touch with what's happening. And so scope is not going to match the skills and the knowledge that are our students have. And so that dialogue is occurring, and it's occurring a lot more regularly. OPA does a lot of work with the pharmacy schools to better understand where pharmacists are, where pharmacy students are, their abilities, so that we can integrate them into teams and we could work with them and support them in doing a good job. So I think that has to continue to happen. We need to make sure regulatory aligns with academia, which aligns with practice, and everybody can kind of see that there's a balance there, and there's a disconnect when those things are not aligned, those folks aren't speaking.
Yeah, it's such a good point. So we talked about the incoming batch of pharmacists. Donnie, as a seasoned pharmacist, how do you see us bringing everybody along for the ride, and where does that?
First of all, seasoned. I don't think I've ever been called that before. I'm the old guy up here, so let's just get to the chase there. I think what happens is, so I have students that come in, the University of Waterloo students, some of them are here today. They're ready, they're trained, they're ready to go. And they come to the pharmacy and they're full of energy, which is great. And we want them to provide that service to our patients. And they do a great job. And our patients appreciate everything they do. And so the younger pharmacists have been trained that way. They're ready to go. But the seasoned veterans around the room, Sean's still in the room, so he's one of them. I think we've been doing this all along. It's just, what was termed minor ailments. I was sitting around the board table a long time ago at OPA, and we said, minor ailments, we need to be paid for this because we're doing it. So pharmacists have always been doing it. And I think the revenue stream needs to be there. So everything that Nardine said, I 100% agree with. Like, we're right there, but reimbursement has to match. As a pharmacist owner, I want to provide all the services I can, and the only thing holding us back is revenue. So, you look at Nova Scotia, and when I sit at a board table with a national organization, they kind of laugh at us in Ontario. They look at our fee, they look at what we get paid, and they kind of laugh at us, right? We need to be up there. And Nova Scotia, when they ran their pharmacy clinics, they were being paid $7,000 a month to run that clinic from the government. We need funding to be able to do this. And with the physician shortage, we're the obvious professional to take that role on. So I think, to keep building it, I think, to have pharmacists in this room, they're all doing a great job, everybody here, taking that student, being a preceptor, driving that energy, making sure that we're moving the needle forward. When Marshall was at the college as a registrar, he talked about the gray area, and I still talk about that because no matter what we get to, there's more gray area to find, and we just need to keep going into that territory.
Yeah, I love that. I think a lot about this idea that you've got a incoming generation of pharmacists that still has the enthusiasm and excitement and sort of like that dream of what could be, and you've got a profession that's seasoned, got so much experience, such a wealth of knowledge, and how do we put these, we're all in the same team, how do we create situations where we can learn and grow together and from each other in a way that elevates us? So moving on this topic of advocacy, Justin, I'm going to ask you, so what role does the patient demand play in shaping regulatory changes? And do you think that the increase in public awareness will translate into stronger advocacy for expanded pharmacy services?
Well, I'm so happy I'm following the wily vet over here. That's teed it up so nicely for me. But I'll be crass to sort of start it off purposefully. You need people to give a shit. And it's true, whether it's the policymakers, whether it's the public, whether it's within the profession or other professions. And I use the example of storytelling, and I think your campaign, Danielle, at CPHA is about storytelling. It's about what this means to healthcare in Canada and to Ontarians, about access where they can't access primary care services today in a timely fashion. But people care about a lot of things, but when the rubber hits the road, if there's not money, it's about politics and money. In life, that's generally how things roll, even if we disagree with certain decisions that are made at a political level. You think of Indigenous peoples and reserves that still to this day in 2025 do not have clean drinking water, right? If people gave a shit, if they truly cared, there would be drinking water, safe drinking water on reserves. That's an example of advocacy that's failed, right? Even though if you walked around any dinner table, people would agree, nod their head that absolutely, as a Canadian, I'm disgusted that there's not clean drinking water on reserves, right? We can do it. We just haven't made it a priority because there are other things. And in healthcare, we should be getting the clean drinking water of healthcare in terms of getting access through proper funding, enabling scope. There's no question that demand and public opinion is what drives decision making. It comes back to being at the dinner table and it being a conversation. Prior to the pandemic, people were not necessarily talking about pharmacists at their dinner table. They might be in a specific situation, but generally when they thought healthcare, they thought doctor, they thought hospitals, traditional institutional care. And when that starts to have a gap, pharmacists matter, and you do matter. And every interaction you have with the patient is the grassroots public opinion and perceptions that are changing that will drive policy decisions at a government level. Because government does all the time just trial balloons on public opinion. It's what drives. It doesn't matter the partisanship, whether it's liberal, conservative, they will shift based on that public opinion. So in terms of demand, the changing perception that patients have of what it means to access care in a pharmacy as a healthcare community hub. They see a pharmacist 12 times more annually on average than they do any other healthcare provider, means that they demand change because they need this access. And we are a trusted healthcare professional in ways that we've demonstrated through the pandemic. So now we're building that momentum to make sure that policymakers understand. And let's be honest, a patient in Ontario is no different than a patient in Nova Scotia or Alberta. By the same token, a pharmacist is no different than in Nova Scotia, Ontario, or Alberta. We should all be practicing at the same level, autonomous prescribing and well-funded. The fact that Ontario has unfunded services is ridiculous, and it's a lack of respect. So that's where we need to drive an aligned message, build out the village. We need to support our associations in delivering that message, both to the public through public relations campaigns and a digital ongoing perpetual campaign to drive that trust and perception, but to convince the policymakers at the end of the day, the government of the day, to fund these things. So we are making some progress, but there's obviously lots of work to do. So making people care is the first step, and then translating that into real policy, healthcare policy that's going to make a difference. In Ontario, we have this primary care initiative that Dr. Jane Philpott is heading about what is primary care defining practice models. And one of the things we've said is that there are multiple practice models. They're already in existence. We don't need to reinvent this or have pilots or anything like that. We just need to fund it. And we need to continue to tap into that with the scope of practice to enable it. So that's, from a public perception, we've got that. So now we just need to keep driving.
Well, it's so interesting because I think about the pandemic and the fact that we were providing primary care. There was no other option. And so when you don't have somewhere to go, you go to your pharmacist. And so we've been doing it. And so now it's just a matter of getting recognition and support and continued investment to allow us to do it more. And I think about advocacy and the role that each one of you plays when you show up to provide care in your pharmacies to your patients, to your communities. That experience is so critical because you don't know who you're providing care to, whose daughter this is, whose spouse this is, whose parents you're caring for. And I feel like when we show up to deliver care in a way that represents the profession at its best, that trickles, right? Like that, those are the conversations we want to have. That's the word of mouth advocacy that comes from being around other pharmacists that continue to remind you that there's more ahead, and it's a good news story. We just have to get through the mud. So Siva, I'm going to ask you.
Can I
Yeah,
interject?
please.
I just want to say I agree with what's being said, and I think getting the public on board and getting them to care is a really strong point. But I want to also say, maybe for the CPHA advocacy campaign, and even for Ontario, there's something that was so effectively done in the UK. So I don't know if anybody's familiar with it. It's called Think Pharmacy First. It's a campaign that they've launched years ago, and they reimagine it every year. And they actually get physicians to come out in advertisements and talk about how much they believe in pharmacists and the care they're providing, and how going to your pharmacist for care for a number of ailments is actually relieving the pressure on them, and they're able to see and deal with more complex cases. And I just think that would be so powerful in Canada if we had, because our patients, they could be on board, they could give a shit, they could, but then if they're worried that their doctor is not going to accept this, or they're going to get dinged for going to see a pharmacist, they're going to shy away from it. So if we can get physicians to speak on our behalf versus us preaching to the converted, I think that would go a long way as well. And I think that the UK's done a really good job of that, and we should look to them to model that campaign.
Donnie?
If I can just add, that's exactly what's happening in Nova Scotia.
Yeah.
Right.
So, the government went out, sent mailings to everybody. They're on social media talking about the role the pharmacist is playing in those clinics. And now that there's almost 50 clinics, what's happening is you go to the Emerge, and it's something that should have been dealt with at one of the pharmacy clinics. They inform the patient, don't come here, we need you to go there. And it's reduced emergency visits like 9.2% over the past year when a population is growing. So that speaks volumes. And, when you're talking to government, and Justin and I have been in the room too often with ministry officials, the bottom line is when you can show them you're saving them money, there should be money in the coffers for pharmacists.
Yeah, it's all about the storytelling piece, and it's about showcasing those examples where it's working. And again, I think what we're recognizing is that when somebody else tells our story, whether or not it's a patient or another profession, I think it lands more because you get to see that there's actually something here. And when you have a healthy pharmacist-physician collaboration, and I've heard of models, like there's a physician clinic in Saskatchewan where they only take UTIs as referrals from pharmacists. So if you are a patient at this clinic, you go to and you have a UTI or symptoms of a UTI, you go to the pharmacist and they will tell you if you need to see the physician. So that's just another example of creative ways to leverage the knowledge and skills of pharmacists in a way that is in service to healthcare overall. So Siva, we've talked a little bit about the demands, and within the workforce, we're not a big workforce, and there's projections that we will continue to struggle in terms of numbers of pharmacists. So the demands of pharmacists have increased dramatically in the recent years. What are some of the most urgent steps we need to take now to support pharmacists' well-being and job satisfaction?
I'll back up before I go there. So I've got one of my former students here, Rebecca, I remember during the pandemic. we must have done about 200-300 Ozempic starts, right? When all the physicians were closed, about 200-300 SGLT2 inhibitor starts, you're nodding along. All we do is we looked in Clinical Connect, someone's eGFR is below 60 mils a minute, and the physicians loved it, right? So I just wanted to just reaffirm what Nardine and Daniele were saying. We already have the skills to do all this. These medications are some of the most harmless medications known to man. We can manage these medications, and it doesn't make sense that we're not right now. I do in the family health team setting I work in. So I chase down A1Cs, I can initiate for hypertension and diabetes, and all the pharmacists that work with me at the family health team can do that safely as well. So even, because I think I qualified in 2008 in the UK, so I think I'm on Donnie's level. Like, I think 40% of my syllabus was medicinal chemistry. So even the pharmacists from the Stone Age, like me and Donnie, can like do this kind of stuff just because of what we're working with. But to answer your question, so I was working with Dr. Nardine last Thursday in the family health team, and the single biggest thing is record keeping and documentation. So the guys at MapFlow do a great job. I switched to MapFlow in December when I renewed my OPA membership, just because operationalizing the clinical decision making is the biggest workflow challenge. We're not going to be able to do it if we can't. And the reason why I'm talking about my physician colleague is I saw AI in action in regards to writing SOAP notes and clinical documentation. It's just remarkable how much time it saves. So, things like the MedCheck program, imagine being able to do minor ailments and it just picking up what you're saying to the patient and having the SOAP note prepared for you to just edit. That's what Dr. Nardine had when he was doing all his consultations. He's doing all sorts of things that required physical exams, things that didn't. The AI just picked up on it like that. So what's lacking in pharmacy, I think, to relieve pressure and also to allow us to be able to do what we want to do is vendors that are incentivized to incorporate things like AI into clinical decision making and documentation, because it's really holding us back right now.
For sure, and it's so interesting because you think about what are the enablers, right? It's so we have the competency, so what are we missing? And I think about myself. I practice, Monday to Friday in a hospital setting, collaborative care setting, access to an EHR, interprofessional colleagues, and then on Saturday I'd work in a community pharmacy, and I was the same clinician, just completely alone. Didn't have an EHR, didn't have relationships with my colleagues. Like, it was unfair because the patient that was in front of me was the one who was being impacted. And so how do we figure out ways to bring this system together? So I'm curious if anybody wants to jump in here. If you could change one thing right now, what would you change about pharmacy practice in Canada? And how do we crack this?
Oh, Donnie, go for it.
I think, again, I'm not speaking on behalf of any organization here. I'm just speaking on behalf of myself. I think if I could change one thing, it would be a federated professional leadership body where all the current professional leadership bodies feed into in some sort of established governance process, because the fragmentation of professional leadership is holding us back tremendously. The Ministry of Health not just speaking to OPA, for example. I'm not trying to say, they should just, but they should. There should be one person sort of representing us, right? Or there should be a federated body where, say, CSH, CP, CPHA, OPA, like all them feed into, because the fragmentation is meaning that the stakeholders that determine what we do don't get clear messaging, and it's holding us back.
It's difficult. Yeah.
I love that.
I'm just going to go on with what you said, Siva, because it's bang on. So often at the decision-making table, we have worked diligently at OPA over the years to expand what pharmacists can do and how we get reimbursed for it. And it's a shame that, we've been in that room, we've made decisions, and then outside forces, whether it's somebody in our own profession, whether it's a corporate company knocking on the door, whether it's a wholesaler knocking on the door or whether it's the Ontario Medical Association knocking on the door, changes what the platform was going to be. And so, yeah, if you could get rid of that, it would open up the doors for us. So often, we worry about what OMA thinks in this province. And, I keep harping back in Nova Scotia because it's the epitome right now of what young pharmacists would want to do. They'd want to work in a pharmacist-led clinic where doctors and nurses are working with them together and supporting them and not feeling like pharmacists is taking a chunk out of them, because they're not. They're working collaboratively for the patient. So if we could get there, I think that would help us in the long run.
Yeah, I think building on that, it's about sustainability. So it's sustainability of the profession to practice with autonomy. It's about fair competition and eliminating some of the restrictive PBMs and PPNs that limit patient autonomy. And it's really about sustainability, the profession, and how we operationalize the services, how we support the mental well-being of our pharmacy professionals, and we need the sustainability of the funding across the entire pharmacy ecosystem, from supply chain through to the delivery of the care in a pharmacy, because we are faced with some significant threats now beyond our domestic borders. We need to build our own capacity from a supply chain standpoint, which is going to require investment. We've had a race to the bottom in this country around cost of goods, or the price of medications, which has put downward pressure on the co-dispensing reimbursement model. So part of this is to move where the puck is going, so to speak, and have a model that we can continue to build on with services that are implemented on top of a transactional drug distribution model. And that's very unique, and most businesses don't have that. And we're there. We've put in things like appointment-based modeling, store configurations have changed, pharmacists are trained to do this, but we need a sustainable model around it to support it. And that's really the role of the advocacy bodies, and to be aligned with not necessarily it's going to be a single voice, but it has to be an aligned voice of representation, and to be able to continue to have influence and relevancy when it comes to affecting change around health policy.
Yeah, and what's really interesting is that you talk about, the next generation of pharmacists, and we have data to show that they are willing to relocate, to go to provinces where they are able to use their scope and to build the practices that they want. And so when you think about our health workforce, our pharmacy workforce, you want to be a go-to province, right? You want to attract the best talent, because that's going to be better for your own provincial healthcare system. And so there's lots at stake here by really reimagining what healthcare could look like in Ontario. So if I think you wanted to say something.
Yeah, I just wanted to, something from the morning session with Simon, sorry, I don't know your name, the lady that asked that question to Simon. It was a really good question, and it was a bloody good answer as well. I didn't know that if you had that criteria, they would just cover it third parties. But it was surrounding physician communication, and you touched on it with the OMA communication there. So I work with 4 family physicians in the other job that I work with. That messaging doesn't speak for what family doctors think of pharmacists. Mm-hmm. So speaking on the other side of the facts, I wanted to give up 2 clinics. This is a true story. So I work with 4 doctors, and it's like just a lot with all the college stuff and all that stuff. So I went to 2 of the doctors and I said, look, I might quit this part, so I just do 1 day a week. And they're like, Siv, please don't quit. And it's not because I'm a great pharmacist, it's because pharmacists are incredibly efficient at managing diabetes and hypertension, and physicians know that. So whatever marketing you're seeing, and if you don't get the facts back that you expect or want, I just want you to, my perception is that 95% of physicians appreciate what you do, they recognize what you do, and they hold your expertise valuable, because there's stuff that you do that they can't do, and you don't see it. But working with physicians, they don't know how to do insulin dose titrations. They don't know how to do adjustments of medications to the same level that we do. Do you know what I mean? I'm trying not to sound arrogant here, but you guys do know a lot more in that regard. You guys don't know how to do a physical exam on a patient, right? But in terms of medications, you do know a lot more than some of our other healthcare colleagues, and they appreciate that.
Yeah.
Yeah,
Nardine?
I mean, I don't have a lot to add to these brilliant minds, but I will say what I want, in addition to the sustainability, is for all of us to then go out. Nova Scotia did it well, where they're talking about the results. These are the outcomes of pharmacist-led care. So it's great that we're doing all these, siloed projects, and I'm sure Siva is having an amazing impact on his practice, and every one of you is having a great impact. We need to talk about the outcomes, and we need to publish these outcomes. So, academics, we are tasked with doing just that. And that's why we're gathering feedback. We're using MapFlow, for example, to get follow-up feedback. So we know, did patients improve? Was it effective after the pharmacist intervened? Was it safe? And then use that to further advocate for enhanced scope and to just demonstrate that we are valuable, we are doing this, so that people trust it. Because right now we're creating noise, and give us scope, give us this. Yeah, now you have it. Where are the outcomes? And I've had physicians who have said to me, pharmacists notify me that they prescribe, but I don't know what's happened after. I'm not sure if the patient's gotten better or not. We have that data, we're tracking it, and now we can really step up and use that for advocacy purposes and other purposes to say, here's the impact pharmacists have had, here's the percentage of patients who have improved. I'll tell you, our MapFlow data to date shows 97.8% of patients at follow-up have complete symptom resolution or an improvement of symptoms. That's huge. That means we are having an incredible impact. The most recent stats out of Saskatchewan were 10 years ago, and they showed 78 to 81% effectiveness. So symptom resolution or improvement was only that. So we're doing a lot better. In Ontario, 99% of all community pharmacies have submitted at least one claim to the Minister of Health for minor ailments. 99% in just 2 years that we've had this expansion of scope. That's phenomenal, right? But we need to go out and say that. 2 million claims have been done for minor ailments. We need to go out and really proclaim that this is our impact, and we now have the ability to triangulate this data with ICES data and look at number of patients who are seen by providers after pharmacist-led care. And right now I can tell you preliminary work out of the University of Toronto is showing that very few are being consulted with as primary care providers after the pharmacist has seen them. So again, further demonstrating impact. So in addition to sustainability, in addition to all this, really showing the data behind the impact of our care, because I don't think a lot of other professionals have that same level of rigor when it comes to their outcomes data.
Absolutely, and we need the evidence, and we have the evidence. So now we just need to be bold and present it and own it too, because I think pharmacists historically haven't. We have an identity crisis, and we just need to show up as that best version of ourselves. So I am not a great moderator because we're at time, but I want to leave. I don't know, where's Nishan? Do we have time for questions?
Yeah, we have time for a few.
Just a few questions if anybody has anything. No, I saw there's a hand there.
So, how about the Bill C-64, and where are we going? Do you think that the authorities are moving with a reasonable speed in implementing?
You want to?
Sorry?
Bill C-64.
So pharmacare?
Yes.
Yeah, okay. So I'm not sure, are you asking where are we going with pharmacare in terms of next steps?
The authorities are moving forward with the reasonable speed to implement that in practice?
So there's a lot of detail around pharmacare that's unknown, and some unpredictability with the federal election. Yes, there's legislation that defines pharmacare as single payer, but we also know that the Liberals before the election were very careful not to use the language single payer, but talk about coverage for all Canadians, which could mean a multi-payer mixed model that fills the gaps. The CDA, which is a Canadian drug agency, is sort of in charge now. The super agency is taking Cadith in there. Has also talked about national formularies. It's talked about bulk buying, even though governments don't buy drugs, but talking about the pricing component. And to the degree that that's going to be implemented and how long and how much money is going to be put to this, because the first federal budget that had any earmarked dollars for pharmacare was only $400 million, which is a paltry amount for the two classes of medications that they've announced thus far, being contraceptives and diabetic medication. So we know that there has to be more money put to it. And what's likely to happen is that, again, it depends on the federal election, but if it's an either Liberal majority or Conservative majority, and this is my opinion, not necessarily fact, but based on what we know of their policies and where the positions have been, it's likely to be a mixed model. And it's likely to, even Poilievre has said he would not take away the two that have already been announced. So it's then going to come down to bilateral agreements that some are already signing. They're signing MOUs with, I think, 4 provinces now. And the nuance there is going to be simple. It's money, right? It's how am I going to administer this, and how am I going to pay for it? And in Ontario, the inside baseball around Ontario is that the government in Ontario gets about 1 to 2 billion in PLAs, right, in rebates that are not transparent. We know this from the Auditor General's report. If a pharmacare program comes in and you're, Jones and Ford, and you're looking at this saying, okay, where's that 1.2 billion going to come from, right? Because it won't be a need for PLAs on a formulary if you have a national one, and if you're guaranteed to be on the formulary for these medications. So there's a lot of nuance to this, and ultimately politics, right? Because in Ontario, the government has said they support a mixed model, where it's 60-40 now, private to public. And, again, it's going to come down to, I think every Canadian believes that no Canadian should be left behind, whether you're underinsured or uninsured. But how it's implemented, no one's really articulated that yet. So we'll find out post-election where the priorities go. But some form of national pharmacare, at least with those 2 medications, will take shape. I don't know if that answers your question, but.
I'm not sure who's picking questions. I see one there and then one here.
My question for everybody, what are we doing about Mark Holland's interpretation of the Canada Health Act? Like, what are we doing to update ourselves to get on the trail?
I can jump in on that to some degree, and then others. Well, a lot of that was theater, I'll be honest. So it was an interpretation. There's no real follow-through. Again, we have an election now, so it'll depend on what happens after that. He was also moved out of the portfolio shortly thereafter. I'm not saying that that was related to that, but I think it's a good conversation, and we are having that conversation at a provincial level. Keep in mind that the provinces are the ones that still fund this, right? So if you move, I think, philosophically in that direction, which we probably all agree makes sense, right? I mean, if you can perform the service and one's paid for it, the other should be, no one would disagree with that. The question will be, what's the opportunity cost from a government standpoint, and how do we make sure that when we think about primary care and the evolution reform of primary care, that our model of care is part of that, and that we're tapping into it, which includes accelerating to autonomous prescribing and getting paid for it. So I think there's alignment, although I wouldn't put too much stock in that particular interpretation at that time. There was a lot of politics behind it.
My 2 cents is that it's a conversation starter, and it's really just I think it's really good for us to have politicians speaking in that way, because even though the implementation and the reality of and timing and how that would actually come to life is not clear, the fact that we're talking about that or thinking about that is the win here for us, regardless of whether it actually comes to fruition or not. So, but yeah, it's that reinterpretation. Nothing actually changes other than the conversations that we're having about it now. Yeah, Simon.
First, thank you so much for your input. My question goes back to the change in the pharmacy profession and in the practice. And there was a qualitative study by U of T about specifically the change in the pharmacy, and it always starts with change in regulation. And when minor element, and Nardine can tell, when we started with change in regulation, a lot of pharmacies didn't jump on it because they didn't have the system, they didn't know anything, the training, everything came back. So again, to our profession, our pharmacists, how to do an efficient change in our practice from the inside.
Yeah, sorry, I'll just say the question again based on what I've heard. They asked me to repeat it for the audience at home, and I have just started to do that now. So my question, the question you have is around the implementation, right? So a lot of times we wait for the regulations, and then when the regulations are we're good to go and we aren't ready and we aren't prepared. We saw multiple examples of that where we're sort of catching up. So how do we handle that?
I think, we look at this guy next to us. I mean, OPA is huge. I mean, if you're not an OPA member and you're operating a pharmacy these days, it makes no sense to me. Yeah. They have the tools. They're building the education around it ahead of time. When you look back again to Nova Scotia, their association, PANS, has huge amounts of resources available for pharmacists and owners to implement, to make sure they're doing these things correctly, quickly, efficiently. I mean, the bottom line from pharmacy business is, I remember when I was around the table when they were talking about meds checks, and they said, well, it's going to be $60 and you're going to spend this much time. No, that's not how it works. I know what $60, how much time I can afford with $60. That's how I'm going to make it work. Same thing with minor ailments. If it's $19, you know how I'm going to do it? What works efficiently for $19. That's what they're getting. It's all a matter of dollars and cents. So when they're announcing new minor ailments coming out, knowing what's coming, knowing where we're going to be at. Look, minor ailments was a huge deal for this government. It's a huge win for the Ford government. They speak volumes about pharmacy and how we've implemented it. So it has been a huge success. And I think that's thanks to everyone in this room. But I think as we move forward, look at CPHA and OPA to take that lead. Hopefully the college, and pass it down to Siva, are on side and help us out that way and make life a little bit more realistic.
Do you mind if I
jump please.
In? Simon, great question. I want to add one more lens to it. I think one thing we lack, and I bang on about it all the time, so sorry if I'm being repetitive, but we lack a postgraduate faculty of pharmacy here. Mm-hmm. So I think pharmacists like me, Simon, who qualified in 2008, if you had a postgraduate faculty of pharmacy that set the standard for how a service is to be provided, and I know some of you guys don't like micro-credentialing, it's not really that cumbersome, where you test competency and you test the competency required to actually provide the service. And I get what you're saying, Nardine, that the current students don't need to. I'm a preceptor too, and I see all that. If we had that, I don't think anyone can challenge a pharmacist who's providing that service. Can they really be challenged if they're providing it appropriately? Do you know what I mean? So even with minor ailments, I strongly believe we should have a certification for that before we provide it, especially pharmacists like me. Like, I did the OPA course and it was incredible. Thanks. That's great. But I believe it should be mandatory and there should be a testing of competency, just to make sure that, look, if we're going to get more services, and what Nardine was saying, if there's audit provided to see the effectiveness of it, what's the harm in testing competency and getting credentialing for it? Does it harm the public? Does it harm the profession? I don't think it does.
But I'm sure there's a cost to it.
In the grand scheme of things, right?
Yeah.
They do it in Alberta, and they do great over there, right?
It's really interesting. I feel like this could be its own topic, because I have thoughts on that too. I'm of the mindset that, we don't need to get into it, but I'm of the mindset that if you have a license, I think that you should, just like other health professions, like, you don't tell a physician you aren't qualified to perform surgery. They just know, like, if you're a surgeon, you're a surgeon. Like, when you have a pharmacy license, I think that you should be granted the professional autonomy to practice the way that, and your limits, right? I don't know, that's just my thought.
Can I ask one
question?
Do you know how to read a NMR spectroscopy? An NMR spectrogram, do you know how to read one?
I have a chemistry degree.
Oh, okay. Who doesn't have? Okay, Rebecca, do you know how? You qualified in 2020. Do you know how to read? Yeah, you don't even know what that is, do you? Yeah. It just goes to show our education from
it's different.
Way back. It's just different. So.
Yeah. No, for sure. Where are we at with timing? We're done. Okay. I'm so sorry, everyone.
Wow. I'm almost speechless at that conversation. That if we had time, I would do this for another 2 hours. But we got to keep it moving. But another round of applause, really, for the panelists and the moderator. It was such an incredible and well thought out discussion. So, and for you guys to take your time out, you know, that really means a lot to us. It means a lot to the association, and means a lot to everybody who's in this room today. You know, when I put this panel together, I really didn't expect that the quick yeses that I got from everyone, and I was very surprised. And I know everyone's so busy, so you know, again, thank you for spending your time. I know how busy everyone is, and how many different things that everybody does here. So it means a lot to us, and thank you again. Thanks.
Pleasure.
Thanks.